Okay, I'm going to get started because I know I'm quite conscious that we only have an hour and a half, but we've got lots of people joining us, so I want to make sure that everybody can have a moment to speak and answer all your questions because we have had loads. Welcome and thank you all so much for joining us for our webinar on endometriosis awareness. I'm Carla and I'm the founder of the Endometriosis Foundation, and I'm really excited to be hosting this. I think it would be good to start with our panelists to maybe give a little bit of an introduction about themselves and what they do, and then we'll just throw ourselves into your questions. So perhaps we'll start with you, Rebecca.
Lovely, thank you, Carla. First of all, a big thank you to hosting the webinar. So I am Rebecca Malik. I'm a consultant gynaecologist at University Hospital Sussex. That's based down around Brighton and Haywards Heath. I've been a consultant there for around 5 to 6 years now, and I'm the lead surgeon at the Sussex Endometriosis Centre. I'm also on the BSGE Council and do a lot of work with teaching and training in the deanery. I'll pass on to Jenny.
Hello everyone, my name's Jenny Shaw. I am an endometriosis nurse specialist based in Cwmtaf Health Board in Wales. I have worked in endometriosis for about 8 years now, and I'm also a member of the BSGE nurse subcommittee.
Martin?
Hi, thanks Carla and Rebecca for putting this together. Fantastic event as always. So I'm Martin Hirsch, consultant gynaecologist based in Oxford. I am, like Rebecca, on the BSG Council. I run the international portfolio and trying to help spread the BSG wings and name overseas. I'm a patient advocate as well. I'll pass on to Kuan, who I know very well.
Thank you, Martin. Thank you very much for inviting me to be part of this panel. I'm Kuan Raja. I'm a consultant gynecologist and a subspecialist in reproductive medicine. And what that essentially means is a specialist in fertility treatment and assessing gynecological conditions that could have an impact on fertility. I'm a consultant at King's College Hospital and King's Fertility in South London. I'm looking forward to this. Thank you so much.
Hazel?
Hi there, I'm Dr. Hazel. I'm a former NHS doctor, a women's health nutritionist, author and founder of the platform The Food Medic.
Suzanne?
Hi, I'm a gynecologist from Southampton and I specialised in gynecology ultrasound, and my passion is to make videos which are hosted on my YouTube channel at Gynecology Ultrasound, where I teach people what's possible to see on ultrasound. Thank you for inviting me.
And Jen?
Hi, I'm Jen Moore, or Jen Endometriosis on social media, and I'm an endometriosis and adenomyosis educator and campaigner. And first and foremost, I'm also an endometriosis patient, and up until my hysterectomy last year, I also had adenomyosis and fibroids as well.
Thank you. I think this is the most we've ever had on a panel with me hosting before. So I'm going to try and get the questions out as quickly as possible because I know we've had so many. I think the best place to start really perhaps is with you, Rebecca. You know, what is endometriosis and how common is it?
Do you know what? I think that's a great question to start off with because it is a simple question, but we often get the definitions wrong. And I think it is really important that during Endometriosis Awareness Month that we get definitions correct and really spread or stop the spread of misinformation. So I think the best way to describe it is endometriosis is a chronic inflammatory condition where cells that are very similar to what's inside the lining of the womb can grow outside. And it can grow in a number of different places, mainly within the pelvis. So it can be on the ovaries or within the ovaries themselves, causing cysts called endometriomas. It can grow on the lining of the pelvis, called the peritoneum. It can grow on the ligaments, very commonly on what we call the uterosacral ligaments. It can also grow in lots of other places. It can grow on the diaphragm, within the lungs, within cesarean section scars, etc. So it can really grow anywhere, and that's why it causes a multitude of different symptoms. And I think with regards to how common it is, the statistic that we hear is it's about 1 in 10. But I think if you think about the big diagnostic delays that I'm sure we're going to discuss this evening, I think it is a lot more common than that. And I'm sure Kuhan will touch on this, but in the subfertile population, it is way higher. But again, I'm sure we'll touch on that. So it is a really common condition.
Mm-hmm. And what are the symptoms, the key symptoms that we should be looking out for?
I think it's difficult because it can cause a large number of symptoms, to be honest, and that's part of the problem with diagnosis, because of the large variety of symptoms that it can cause. So classically, the most common symptom is chronic pelvic pain. You can get pain with sex, so dyspareunia. You can get a number of other symptoms as well. So painful periods, dysmenorrhea. The most common symptom out with this is bowel symptoms. And interestingly, around 70–80% of patients, even when they don't have endometriosis on the bowel, will get bowel symptoms. So I'm sure everyone will attest to this. One of the most common symptoms that we hear in clinic is bloating. So bloating, abdominal discomfort, change in bowel habits, diarrhea, constipation. If you've got severe endometriosis, you can get rectal bleeding, classically cyclical rectal bleeding, often a number of bladder symptoms, so painful bladder. And again, if it's significant and invading into the bladder, you can get blood in the urine, and other symptoms as well, like fatigue, lethargy, leg pain, back pain, sciatica type symptoms. It really depends on where the endometriosis is growing, but it's a huge multitude of symptoms that it can cause.
Yeah, and it's interesting that you said a lot of the symptoms with bowel symptoms, because quite often it can be misdiagnosed or confused with IBS type symptoms, and they all are all very similar, aren't they? So the next question is for Rebecca and Martin, which was the kind of just to discuss the treatment options available, both medical and surgical. Whoever wants to take it.
Shall I jump in? Yeah, so I tend to describe them in 3 different groups, and they all tend to be available at most times for patients, unless there are really kind of fixed medical indications for treatments, which I'll get onto a little bit later. But I tend to break them down into non-hormonal treatment options. So that can often include painkillers, but as well as kind of more holistic approaches that are not necessarily medically based. So that might include physiotherapy, that might include some cognitive behavioral therapy, it might include things like acupuncture, heat therapy, cold therapy, exercise, all things that may help for some people, and some of them have varying degrees of evidence to support their use. We then move on to more commonly regarded treatments that most people have heard of, that are called hormonal treatments. So they're all bundled into one, but they can either be then subcategorized into additional hormones or hormone removing treatments. So additional hormones you might consider as, traditional contraceptive pills, whether that's the combined contraceptive pill or the mini pill, which is progesterone only. But then there are other subtypes within that. So you can have injectable progesterones, you can have progesterones that sit inside the womb, progesterones that go implanted, as well as some non-contraceptive hormones that are also really effective, such as norethisterone, Provera, and Dynagest, which is new to the market in the UK in the past year or two. Then the hormone removing agents are things that essentially act centrally within the brain to stop the brain feeding the ovaries and stopping from the ovaries from functioning. So they're commonly described as menopause-inducing agents, so temporary and reversible induction of menopause. And there is the common ones, which are injections, but I hope in the near future we'll have tablet-based medicines that will be able to switch things off internally. I might stop speaking there and hand over to Rebecca for the surgical options.
So yes, with regards to surgical options, the vast majority of surgical procedures are done keyhole, so laparoscopic surgery. And the main aim of keyhole surgery is to really remove all visible signs of endometriosis. I can never find a better term, but the evidence tends to suggest that the more aggressive, and that's not the best word, but the more aggressive you are in terms of the surgical removal, the better the long-term outcomes in terms of recurrence. And there's different ways of treating endometriotic lesions. Historically, there was a big movement of just burning the surface of it, an ablation technique, or removing the whole endometriosis nodule, an excisional technique of removing. And I think the vast majority of people have moved over to removing the nodule for a number of reasons, but mainly there's an increasing body of evidence that it reduces recurrence. what you have to weigh up, and I'll leave that for our fertility specialist to discuss a wee bit later, is that sometimes surgery isn't for everyone, and it really is a bespoke approach depending on the patient's symptoms and their fertility desires, because surgery on ovaries and endometriomas can have a negative impact on fertility. So there are lots of surgical options, but it's all weighing up fertility desires, pain, and other conditions that someone might have.
And I probably should have asked this earlier, but endometriosis diagnosed?
Shall I take that one? Because I'm going to hand this over to Susanna in a second. But in terms of the diagnosis of endometriosis, it is difficult and it's a little bit controversial. I think historically, the gold standard of diagnosis of endometriosis was always keyhole surgery and visualizing the nodules, taking a biopsy, removing it and sending it off for that diagnosis. But there was a recent change in European guidance and certainly a big move, hopefully more so in the UK, to being able to pick up endometriosis on ultrasound. And I think I'm going to hand over to our specialist, Suzanne, to tell us more about how it can be diagnosed on ultrasound.
Lovely, thank you. Endometriosis, as you started by saying, there's 3 different kinds. There's the ovarian endometriosis, deep endometriosis, and superficial endometriosis. And whilst people are still talking about definitions, I think we'll leave superficial endometriosis out of it and just say that at the moment, the vast majority of people cannot diagnose that on ultrasound. Some people can, but the vast majority cannot. Ovarian endometriosis, where you have a blood-filled cyst in the ovary, that can be readily diagnosed on ultrasound, which is mostly transvaginal ultrasound. But if it's a big ovarian endometrioma, a big cyst full of blood in the ovary, sometimes it can be seen through the tummy, a transabdominal ultrasound. But mostly all the scanning I'm talking about will be transvaginal, because the views are so much better than looking through the tummy. It's a bit like transabdominal ultrasound. It's like seeing somebody in the far distance, whereas on a transvaginal scan, it's like you can see it in so much detail, so much, much better. So most of the scanning is transvaginal, which means through the vagina. A little probe sits in the vagina and we can look through the whole pelvis and have a good look around. And so we might see endometriosis cysts, blood-filled cysts in the ovaries or in one ovary, and be able to tell a lot of detail about that, if there'd been any recent bleeding into that cyst, or if it's all long-standing, or if there are any worrying changes, that kind of thing. But the deep endometriosis is a newer understood type of endometriosis, where you can get sometimes very small little nodules, literally a few millimeters in size, which will be behind the womb, in the ligaments behind the womb. It can be in the bowel, in the tissues that are deep in lots of fibrosis, scar tissue caused by endometriosis, or it can be in the bladder. And so these nodules can be tiny or they can be very large. And you can see them very clearly on ultrasound if you have a good machine and if you've been trained how to do it. And that's where the problem is. And so at the moment, the diagnostic delay, so the time when somebody goes to see the GP with painful periods, let's say, and the time that they get a diagnosis, on average is 8 years in the UK. In America, it can be up to 10 years, and it varies a little bit around the world, but it's mostly about 8 years. And I believe that a significant amount of that delay is because the people who do scans, who are mainly sonographers, highly skilled technicians who do ultrasound, but also radiologists, doctors who specialize in imaging, and gynecologists who use some imaging in their day-to-day work, that these professional groups haven't learned how to diagnose deep endometriosis. And if you don't know what it looks like, you don't see it. And so scans can be reported as being normal, when they're not normal at all, but the person just hasn't known where to look or what it looks like. And so the scan is called normal, and that is a huge problem, because then the patient goes back to the healthcare professional who asked for the scan in the first place, and that person may say, your scan is normal, therefore you don't have anything the matter with you. Whereas it's now recognized, even in the NICE guidelines, that if the scan is normal, that should not stop the referring clinician from referring that patient onto a gynecologist for consideration of, could this be endometriosis, or shall we do some different tests? And people who diagnose endometriosis all the time, and I'm thinking, you know, Martin and Rebecca here on the call, and they, when they get to meet somebody, will have already, I think, from the history, a jolly good idea if there's endometriosis, from their scans, and maybe a laparoscopy, but at least that person will be in good hands and will be believed. I think that's a very, very important issue.
And Suzanne, you mentioned you had a YouTube channel. Do you kind of use that to help educate these sonographers to learn, you know, to get experience in scanning for endometriosis?
Yes, yes. The YouTube channel is called @Gynecology Ultrasound, and Gyna is GYNAE. It's a sort of Latin way of writing it, @Gynecology Ultrasound. And it's a free YouTube channel. I haven't monetized it. It's free for everybody. And the idea behind it was to make videos that would show people what I can do, because I've been very lucky and I've had a huge amount of time to dedicate to learning to scan. And I enjoy it very much. I like to work out what's wrong with someone. So I've made lots of videos, mainly to teach clinicians how to do what they do, and what endometriosis looks like, and what the technique is for how to diagnose it. But also, increasingly, I find patients come to see me, have found me online and have watched some of the videos. And I love that, because that way the people are empowered to say, you, me, obviously know what I'm looking for, but if I was to see someone else, how would I know if they know what you do? And there are some red flags if they don't talk about the ligaments behind the womb, if they don't talk about the muscle there in the bowel, if they don't talk about those kind of things, then probably they've just not had the opportunity to learn. And so the YouTube channel is a great way for people to learn, for patients to see what's possible to see on ultrasound, for clinicians to learn how to do it. But also I'm involved with helping to set up groups where we can do hands-on training for clinicians. And one of those groups is within the British Society of Gynae-Endoscopy, the group that's hosting this webinar. And that's a very exciting development, because these are exactly the people who come across most patients with endometriosis. But also we're setting up at the moment, of course, at King's College London, for sonographers, gynecologists, radiologists to learn how to do this actually with theory and hands-on. And so it's a huge task, because so few people know how to do this, but you have to start somewhere. And so we've started, and I think this year is, I think, fairly transformational. We've made huge strides this year, and I'm hoping that in due course, people will have been to King's and have got an advanced qualification. They will be a member of BSGE and come and, you know, see all the latest research and developments. A member of BMUS, British Medical Ultrasound Society, similarly. And that we can, as teamwork, believe the patient when they have symptoms, and then take them from there.
It's reassuring. I remember I had my first clear normal scan at just 14. I mean, had that person had been, you know, experienced and qualified enough to find it, gosh, my life could be very different. And back to you, Martin. For adolescents, younger people, the kind of the pathway is a little bit more difficult, isn't it? A bit more tricky to navigate. Can you kind of explain that pathway a little bit? Because we had quite a few questions, especially from parents, around adolescents and endometriosis.
Yeah, apologies. I was actually just typing an answer to the question in the box about adolescents. And it is a really challenging disease, both in adolescents and adults. And we know, unfortunately, that the waiting time for those people that have symptom onset in adolescence is longer than the waiting time for diagnosis when the symptom onset is in adulthood. And to me, that says one thing very clearly, that as a body of professionals, we're not necessarily listening to the people in front of us as we should be, and taking, you know, the leaders of the future as seriously as we should be, and listening to our adolescents that are coming to see us with pain. And so the NICE guidelines are very clear that people, even under the age of 17, should be investigated along exactly the same pathway as adults. There may be some slight tweaks in how those investigations take place, because a transvaginal ultrasound may not be appropriate. And in those situations where the index of suspicion is high, then a referral should be considered to secondary care. And in secondary care, that's when additional resources like access to super high levels, sonographic skills like Suzanne or MRI is available. So, I think there is a lot of work that needs to be done to ensure that waiting time comes down, and that waiting time, particularly for adolescents, comes down, because, it's such a crucial time in people's lives when they're studying, when they're socializing, when they're essentially forming the person that they're going to become, for that to be taken away from underneath their feet by a condition that is so debilitating and that then people don't necessarily listen to them about, is a real challenge. So it's something we do need to focus on moving forward.
Yeah, and there seems, putting the waiting times aside, there also seems to be quite a barrier to get past into secondary care as well. So by the time that all just adds up, doesn't it? Okay, next question is back to treatments. And we had a lot of questions around GnRH analogues. Are they safe, and what we need to know about them? Rebecca, I don't know if you might be best for that one.
Yeah, and it can be a controversial subject, GnRH analogues. And Martin kind of alluded at the beginning as to how they work. So the GnRH analogues are the hormone blockers that we were talking about. So the way that GnRH analogues work, first of all, is that they stimulate the ovaries to initially produce lots of estrogen, and the hormones overproduce hormones, and then because of that significant increase, it then downregulates everything, and essentially it is making the person that's taking them menopausal. Now, there certainly is a role for it, and to be honest, everything that I say, I always end with, it comes down to patient consent and counselling and informed choice. So for some patients, a hormonal treatment and a medical treatment is the right choice, and for others, it's not. The main thing with Zoladex is just knowing, or GnRH analogues, is just knowing what you're taking. There are side effects from it, and you're not going to lie. You can get hot flashes, night sweats, hair loss. A multitude of menopausal symptoms that you can get with them. They can be mitigated against by going on HRT as well at the same time, but you can get horrific side effects. Some people do really well on it, some people don't. There's a big concern, and I get asked this a lot in clinic about the potential fertility effects of Zoladex, but there's no significant evidence to suggest that there are long-term negative effects of being on Zoladex for a short period of time. It is not licensed for use beyond 6 months, but it is on a one-to-one kind of basis, and if that is the only treatment that works, then patients may want to proceed. The main risk that we worry about is osteoporosis, and that's something that we have to be really, really careful about. So if someone has a family history of osteopenia or osteoporosis, then perhaps that's not the right treatment choice for them. But if someone's on Zoladex long term, then bone scans and monitoring that is really important.
And there's also an option to have an add-back therapy too, isn't there, for people that do kind of have that, choose to have the GnRH analogues?
Exactly, as you said. So if someone is having horrific menopausal symptoms, then absolutely they can have add-back HRT. Some people use tablets like Tibolone. You can have patches, etc. If you're on it long term, then it's worth being on HRT to reduce the risks of that estrogen deficiency. And there is a study at the moment. Oh, sorry. There is a study at the moment looking at using Zoladex I keep using Zoladex, but GnRH treatment for recurrent pain in those that have a previous history of endometriosis, and the REGAL study. So it has its flaws, every study has its flaws, but it will be interesting to see the results of that.
On to our next subject, which is fertility. So we have an amazing fertility expert here. Can we just open it with, how endometriosis can affect fertility?
Thank you, Carla. So it's quite wide-ranging in terms of the impact of endometriosis on fertility. And this is largely related to the extent and severity of the endometriosis. So one common way is the presence of scar tissue, which is common in severe endometriosis, particularly between the fallopian tubes and ovaries, which will reduce the chances of any eggs being collected from the fallopian tubes, by the fallopian tubes. The function of the fallopian tubes can also be altered by the presence of inflammation in the pelvis, and also reducing the chances of any eggs that have been released being collected. Endometriosis in a more severe form can cause tubal occlusion, so blockage of the fallopian tubes, and this is one one situation where natural conception may be precluded if the fallopian tubes are entirely blocked and non-functional. Other ways, the presence of ovarian endometrioma, so endometriotic cysts within the ovaries, can reduce ovarian reserve, and that can also have a negative impact in terms of any further fertility treatment that couples may need to have. Lastly, the thing which is probably sometimes less mentioned is pain can be an issue in terms of being able to try naturally, and that is something which I do come across, and sometimes addressing the pain may actually allow couples to try naturally and allow natural conception to take place.
And Kuan, at what stage should surgery be an option when it comes to fertility?
So I think it's largely related to the presence of pain symptoms. So what the evidence suggests is in women who have got, I think Suzanne sort of alluded to, talking about superficial endometriosis and deep endometriosis. The superficial endometriosis is what is largely diagnosed at laparoscopy, and there's some experts who are able to diagnose an ultrasound, but it's largely diagnosed at laparoscopy. And what the evidence suggests is treating superficial endometriosis, so cutting these areas of endometriosis away, can improve the chances of natural conception. There isn't enough data to suggest the same thing with regards to deep endometriosis, which is more extensive. So treating deep endometriosis and more extensive endometriosis to improve the chances of natural conception. In the absence of pain, there isn't enough evidence to suggest doing a laparoscopy, for example, to identify and treat endometriosis, which may or may not be present. So this is something that needs to be personalized with, with each patient's sort of fertility history, how long they've been trying to get pregnant for, the patient's age, ovarian reserve, in terms of what would be the best sort of treatment option. And for some couples, it may be moving on to assisted reproductive techniques.
Mm-hmm. And we actually, with the Endometriosis Foundation, we've been campaigning for fertility support. And so we ran a survey last year, and we found that I think it was more than 80% were concerned for their future fertility, 80% of people with endometriosis. So for those who are concerned, what can they do about it, and what tests are available, and when should they be taken?
I think there's so in terms of one of the sort of key factors in terms of predicting chances of fertility treatment, and particularly in vitro fertilization being successful, is ovarian reserve. And so there are two ways of assessing ovarian reserve, and that is through a blood test called anti-Mullerian hormone, or a transvaginal pelvic ultrasound to assess the antral follicle count. So these are two tests which will give women a sort of baseline assessment of the ovarian reserve, and also will come into play when considering sort of surgery, and particularly surgery on the ovaries. For example, removing endometriosis on the ovaries, it is important to know what the ovarian reserve is prior to that, because as I think Rebecca mentioned earlier, removing ovarian endometriosis can reduce ovarian reserve further. So that's something that needs to be factored in when considering surgery. With regards to sort of knowing the impact on fertility, webinars like this is obviously a great sort of avenue for patients to empower patients. I think knowledge is key to allow sort of patients to make a choice on sort of when to consider starting a family, the options of fertility preservation, what treatment options they should undertake. So this is a great sort of this is a great idea, and I think more of the same will certainly empower patients to better decide what's best in terms of their fertility journey.
Thank you. Martin, you got your hand up.
Yeah, I'd just like to echo what Kuan was saying in terms of the difficulties and uncertainties of knowing what to do in certain situations. And but I think, as you said, that knowledge is key, and knowledge is key in terms of what the ovarian reserve is when you're perhaps a surgeon more than a fertility specialist like Rebecca and myself. And so it's commonly routine practice now to assess the ovarian reserve for anyone having surgery on their ovaries with future fertility desires. And Kuan will know this from his message inbox, because it's very common for me to get in touch with him to find out what he'd advise as a specialist in reproductive medicine for someone that perhaps has an endometrioma and also maybe a low ovarian reserve. because that ovarian reserve is really important if they were to go down the fertility route, but it doesn't necessarily predict whether they will fall pregnant naturally, which is a hard kind of conundrum for the patient to manage.
No. Excellent point, Martin. I was just going to say, touch on sort of the view that ovarian reserve sort of predicts your natural fertility. And as Martin alluded to, we know that women who have got reduced ovarian reserve, as long as they're having cycles where they're ovulating, do not have a lower chance of conception as opposed to a woman who's got normal ovarian reserve. So I think that's important to know, that just having low ovarian reserve doesn't take away your chance of natural conception. However, we know that, for example, in vitro fertilization, ovarian reserve is a key aspect of the whole sort of treatment, as it predicts the ability of the ovaries to respond to the drugs that we use to stimulate the ovaries. So it predicts the number of eggs we're likely to collect from a cycle of ovarian stimulation, and that is key in sort of the next stages of treatment.
And Kuhan, is there a particular time of the cycle where these tests are best to be carried out?
So the evidence suggests that you do have cycle to cycle, so within a menstrual cycle, variation in antral follicle count, so the follicle count on transvaginal scan, as well as anti-Mullerian hormone, but it doesn't actually significantly change that it can be done anytime in the cycle. So I tend to see women, it's something to factor in, and also having sort of expertise in ultrasound scanning allows you to sort of have better detailed assessment of the ovaries and the follicle count. But I don't time it in any particular time of the cycle, and also it makes it far more flexible for patients to have these tests done. Historically, they were done in the sort of the early stage of the menstrual cycle, but that is no longer shown to be necessary in terms of what we're looking to assess.
Thank you. And Hazel, coming to you, what can we do in terms of diet and lifestyle that can maybe help improve our fertility? Is there anything there, any evidence that shows that this can help?
Yeah, and the good news is a diet that supports fertility is typically a diet that would support endometriosis, and that's one of a typical Mediterranean style diet. So lots of colorful fruits and vegetables, whole grains, nuts and seeds. Things that could be harmful are more like processed, saturated fat, high foods. Too much alcohol consumption and smoking can be harmful as well. So really, it's about following a healthy, balanced lifestyle as opposed to a specific diet.
And recommended supplements? I mean, we got a lot of questions about supplements, zinc, and what supplements would you recommend people with endometriosis and those kind of concerned for future fertility and just wanted to live a healthier lifestyle to take?
When it comes to supplementation, we don't have that much robust evidence to say that women with endometriosis should be on specific supplements. There is some interesting evidence around antioxidant supplements, but we're not at the point to say that it's better than having it through your diet. So assuming that you've got a healthy, balanced diet, you don't exclude any food groups, you don't need to be taking specific supplements at the moment. There's no evidence to say that it's superior. Things that I look out for when I'm working with clients is, are they getting enough omega-3s through the diet, through like oily fish, for example? Are they getting enough portions of fruit and vegetables, whole grains? Fiber is incredibly important for endometriosis, as we spoke about earlier, because of the impact on the bowel. And it's a bit of a catch-22 because, as you said, a lot of women have gut symptoms, but also a lot of women with endometriosis have IBS, up to 50% of women. So while a lot of the advice is to have more fiber, some women find that very difficult to tolerate. And so in some cases, it is really beneficial to work with a nutritionist or a dietitian in that case. If you are thinking about conceiving, definitely do take folic acid. And also in the UK, we should be generally taking vitamin D anyway. And that goes for everyone who has endometriosis or not. But that would be my best advice in terms of nutrition and supplementation.
And Hazel, when it comes to exercise, obviously we know you are very, very active. What advice would you give to people who might be just struggling to get going?
Yeah, it's really difficult. And I think if you've got endometriosis, there'll be times of your cycle where it's very difficult to remain active. What I would say is any form of movement is better than no movement. Obviously, if you're finding it incredibly debilitating, then rest is always advisable. But there is some evidence to say that light movement can actually be quite anti-inflammatory and can help boost mood as well. So staying active, even if that's going for a walk, doing yoga, doing something that isn't super intense, isn't going to cause any aggravation of your symptoms. It's also really beneficial for keeping your gut moving as well, and managing bloating. So that would be, it's about being more in tune with your body as opposed to a specific type of exercise is best for endometriosis.
Yeah, and over to Jenny, I'm just being mindful of time. Can you tell us about the role of an endometriosis nurse?
Oh, well, that varies a little bit on where you are in the UK. In England and Scotland, generally, endometriosis nurses are attached to accredited centres. Where I work in Wales, we're not attached to accredited centres, and we're working within the secondary and primary care arenas. So for the majority of people listening, they'll probably only meet an endometriosis nurse if they're having treatment in an accredited centre. So that's one of the BSGE centres that women are referred to if they've got the more severe forms of endometriosis. But I really like, and that's why I've come to Wales, because I like the Wales model, because I believe that actually we have a really good role to play in helping drive down that diagnosis time, in supporting women who have suspected endometriosis and helping them navigate their way through the health system. I suppose the biggest thing to say about my role is that I'm a lot cheaper than a consultant gynecologist in terms of my hourly rate, and hence I can spend an awful lot more time with women. And I think the thing that I do the most is listen, really listen, find out what it is that women actually want and see if we can help them navigate that.
Yeah, and I think that's so important. And I done an event recently with nurses, and a lot of the time you'll see the nurses more than you'll see consultants quite often, and sometimes nurses, your friends, almost like your counselor. So having that relationship is really important, which actually brings me on to the next question, which is for yourself and Jen, which is what support is available for endometriosis patients?
Well, can I start that one by saying not enough, either within the health system or outside of it, really. I don't know whether Jen would agree there.
Oh, yeah. Very much so.
Yeah.
To be honest, I'd say the biggest support that I have found is online, and it's from other endometriosis sufferers. I historically have not had a lot of support come through the medical system, and I know that's the case for a lot of people, a lot of sufferers of endometriosis. I think Martin alluded to it earlier, about, we kind of get to the point of seeing a consultant and we've already had years, if not decades, of being dismissed and not being believed and not being heard. So yeah, I would say that I echo Jenny completely. There is not enough support at any touch point for people with endometriosis or endometriosis symptoms. That could be in schools, that could be from the medical system itself, at work, in society generally and wider. And I find as well that, and I know that from the conversations I've had, I'm not the only one, that you kind of can get a diagnosis and then the support drops off. And so you've kind of been dismissed this whole time. And then they're like, oh yeah, you've got endometriosis. And then it feels like you're kind of pushed off into the void a lot of the time. So there's that kind of lack of ongoing support available for patients. And yeah, so I think, like Jenny said, there's definitely some work to be done, because it shouldn't really be the case where the biggest support that I've had for diseases that have completely changed my life have been strangers on the internet, to be honest.
Yeah, and Jen, coming around to medical gaslighting, which is a real thing, how do we navigate this?
It's hard. I think it depends. My answer would depend on who is asking the question. So if it's the BSGE and the medical community asking the question, I would say acknowledging that it is a real thing, You don't look, nobody goes into medicine wanting to make people's lives harder, right? There's so many other career options you could do if that was your goal. But it's not about attacking a particular doctor or a particular group of clinicians. It's about highlighting a historic and systemic issue that unfortunately women have been expected to internalize in the hopes of accessing treatment and healthcare. And it's something that isn't just happening subtly. And even if it was, it's kind of those death by 1,000 cuts. If you're constantly being told it's normal, it's in your head, it's just a bad period, you start to do that to yourself, and you start to believe that and internalize it yourself. I know that when I was younger, I didn't think I had something wrong with my body. I thought I had something wrong with my head. I thought, why am I not able to cope with this? Why is everybody around me dealing with this so much better than I am? And so it is so important to acknowledge it, and also to listen and accept when we're talking about medical gaslighting from the patient side, to accept it kind of gracefully and graciously, and really hear what we're saying, because some of the comments are outrageous. I was told before my hysterectomy by a BSGE surgeon that he had 3 children, so maybe me not being able to have any children will balance out the environmental impact of his. Like, that's what I was told in a consultation before my fertility was removed. And I am, again, far from the only one who has been told comments like this at every stage of their kind of journey with endometriosis. So that's what I would say. If it was a healthcare person asking the question, it would be to believe us, because we've been disbelieved enough. And, you know, it's just something that is entrenched into the system, that, you know, the first step in that is to highlight it and to be aware of it. If it's a patient asking the question, my advice to navigating it, the first step is do not internalize it. Do not take it on and into yourself and feel like, you know, that you are just weak, or you have a low pain threshold, or you're just not able to cope, because these are all comments that I get in my inbox every single day. So please don't internalize it, and also don't accept that you have to, that's not part and parcel of your healthcare package. You know, you don't have to deal with these comments, deal with these dismissals. It's not what you should be doing. And I think reaching out, being vocal about it, and yeah, just knowing that you're not alone ever.
Thanks, Jen. And Jenny, did you?
Yeah, I just wanted to say, you know, at the bottom of the gaslighting, to an extent, it's a lack of knowledge, a lack of education, and a lack of awareness about endometriosis. And, you know, even just this week, I've been in a situation where I've met a woman who's had a diagnostic laparoscopy, interestingly, after a positive saliva test. And her laparoscopy was said to show no evidence of endometriosis. She subsequently had an MRI that did show signs of quite advanced deep endometriosis. And it's you know, I know it's a really complicated disease to diagnose in clinic, but the fact that women are still going through laparoscopies and being told by gynecologists that they do not have endometriosis, when they probably very highly likely to have, that's a massive issue for the medical profession to tackle.
Rebecca?
It's such a difficult topic. I was going to say kind of what Jenny had said in terms of it's all about knowledge and education, because as you said at the beginning, or I think Jen said, medical clinicians, you know, we don't go into medicine with the view that we're not going to do our best. But I think ultimately it probably comes down to lack of knowledge, lack of awareness, lack of understanding. And that doesn't, I'm not saying that excuses anyone's behaviour, and hearing Jen's comments are, you know, are awful. But I think just being here and doing what we're doing this evening, and all the work that you guys are doing through awareness, the BSGE is doing, you know, all the different societies are doing, I just think that is fundamental to changing what's been a really ingrained problem in gynecology. And to be honest, for most of women's health, it's not just endometriosis. There is a lot of stigma around fibroids and around, you know, all of women's health, and belittling menstrual issues in general. I think it was just a comment I was making. It was disheartening to hear what Jen has said, and I hear it actually all the time in clinic. But I think it is so important we just carry on this process of education, awareness, and hopefully, you know, we'll slowly get there. Because as clinicians, we don't set out to cause harm, but I think it is just through lack of awareness and knowledge that people are having these poor experiences, and hopefully that will just continue to improve.
Yeah, and it certainly has. I mean, we have certainly a long way to go, but I remember when I was diagnosed in 2015, endometriosis was hardly anywhere to be seen online, you know, anywhere. There wasn't this kind of big platform with these webinars, and you know, I had stage 4 endometriosis and pelvic bladder and bowel involvement, and there just wasn't anything available to me to learn, to guide me. So, which brings me to my next question to Jen, is that there's so much information on social media. Is this a good thing? Is this a bad thing? How do we know which accounts to trust?
A really, really good point, but I think it extends way beyond social media. I will touch on it, but you know, it's somebody asked me in an interview the other day, oh, you must be so happy in March, like, you know, endo's everywhere, isn't it great, all this awareness? And I said, well, sort of, but it's actually more nuanced than that, because a lot of the information that is out there generally is either half the story or it's incorrect. So we need to almost rein it back a little bit, kind of make sure we're putting out consistent, accurate information that's inclusive, and then push the awareness train again and get it going. And I think the question that we, as well, when we talk about social media, we almost jump straight to the misinformation on social media. Whereas actually, in my opinion, and in the opinion of lots of other patients, we should be asking as well, why are we turning to social media? Why are we feeling like we have to go to social media to find our answers? And I think it would be that actually a lot of us have been given a lot of misinformation from medical sources, and it's found, you know, either a little piece here and there that adds up, like it's just a bad period, you're just an unlucky one, you'll be fine, or, you know, something really quite serious, which has led to much more complex surgery, much more involved bowel involvement, losing organs. So actually my pushback would be, what about the misinformation that's coming from all these other sources? And why do people feel like they have to turn to social media to get that information? But once you're there, you are right. It's a minefield, right? There's a lot of it. There's a lot of people sharing either their stories or information. And again, like we were saying about clinicians, they don't go into this to cause anybody upset or anybody harm. I don't think anybody shares their story online with the intention of spreading misinformation. But it happens either directly, indirectly, explicitly, implicitly. It happens, and with so much information, it's hard to filter through and find those real nuggets. I would say ask, and it's the same for finding an expert clinician, right? Ask questions. You know, where's that information come from? What sources? What's the experience? I think that's really, really important, to be really curious about the information you're consuming from, no matter what the source is. And I think anybody that's kind of done their research and really does understand the subject will always be happy to talk about it, to tell you where it's come from, to tell you what it's grounded in. So yeah, I think it is a bit of a minefield, but I also think the minefield expands beyond the reach of social media. But yeah, it is a tricky one, and we're learning so much new stuff all the time about this disease. New research is coming out all the time, and it's making sure that that research is decent. The methodologies are good, you know, the pool of people that was studied is good, you know, all these things. So yeah, it's definitely a multifaceted one for sure, and social media is a piece of the puzzle, but I wouldn't say it's necessarily the whole picture.
Thanks, Jen. And I have one more question for you. I'm sorry. Tell us about the role of a patient advocate and the importance of this role.
Oh, good one. So I didn't even know what it was until fairly recently. I kind of stumbled into doing this because of my own experiences. And then I realized that actually it's so much bigger than me, and I wanted to kind of move the needle in a meaningful way. For me, it's split into two camps. So, oh, this is certainly for my advocacy anyway. I don't want to speak for other advocates. But for me, myself, it's split into two. There's the role for endometriosis patients and those who think they might have endometriosis, their families, their loved ones. And that's creating a safe space where they can share their stories, they feel validated, they can ask any questions, and they feel heard and safe in a community where they have traditionally been ignored. So that's the first side of it for me. And then the other side is the more institutional change work, where we're actually changing the landscape for future generations. I have a niece who's just been born, and I look at her and I cannot allow myself to be part of a society where we're not at least trying to change it for them. And yeah, I just refuse to let her down on that. So for me, it's split into those two things. It's the kind of patient support, the patient community, and holding that safe space. But it's also working with institutions, with brands, researchers, to really try and push the landscape and change it for future generations.
Thank you, Jen. And Martin, back to you. We hear a lot around endometriosis being classified as benign. Can you delve a little bit into that?
So I'd like to say that word is not a word that I'm a fan of. I don't think it represents the disease well in the context of the disease. But strictly speaking, it is accurate in its description in that it's not a cancerous condition, but it does not acknowledge that this is a disease that almost exclusively affects people of reproductive age, of working age, of people that are wanting to either start families or be in the workplace and contribute to society, and it chops those people down severely. And it's so in the way that it manifests, it is certainly not benign. But in the way that the healthcare sees it, in that kind of dichotomy of is it cancer or is it not cancer, it comes under a benign disease. But I think there's a lot of work going on with endometriosis and the RCOG for trying to drop the name benign within women's health, within obstetrics and gynecology, and referring to it as either gynecological oncology, which is cancer, or gynecology. Giving us a name that is befitting of what we do, but not necessarily using a term that I think really underplays the conditions that we manage, not just endometriosis, but things like fibroids, things like adenomyosis as well. I see Jen's got her hand up.
Sorry, I wasn't expecting you to come to me so quickly there. Sorry, I didn't want to interrupt. It was just on your point there about endometriosis then sitting under gynecology as opposed to benign benign gynecology. What do you feel? Because there's also been calls, hasn't there, where perhaps endometriosis shouldn't sit under gynecology at all, considering it's such a whole body systemic disease. And I was just really interested to hear any of the panel's views on that, to be honest.
I think from my perspective, while there are still surgical interventions and the surgical skill set is with gynecologists, it should probably still sit with gynecology, but with, and these are essential, but links to other allied specialties. So that's colorectal surgeons, that's urological surgeons, thoracic surgeons, to name a few. You need a multidisciplinary team. You need a team that like working together, want to work together for the benefit of the patient, because no one of those surgeons can manage all of the disease. So it requires teamwork, it requires dedication, and it requires a large amount of infrastructure for a disease that isn't cancerous. And the kind of infrastructures I've just spoken about has almost exclusively been in place for cancers for a long time, but not so much for non-cancerous conditions like endometriosis. And we are, it is a big driving point for the BSGE, and within the UK, I think we have a fantastic setup with multidisciplinary care that I don't think other countries are quite at the same level with. So I'm really proud of what we're doing. We can certainly expand that.
Martin, patients will have access to this multidisciplinary team under an accredited BSGE centre. Can we talk a little bit about those centres and where to find them, how to find them?
Very easy. Go on the BSG website. I think one of the tabs at the top is centres, and then you can put your address and find your closest endometriosis centre. Now, referral to an endometriosis centre would either be performed by your GP if you live within the catchment of that hospital, or from your local secondary care centre if perhaps you've been found to have endometriosis that needs to be managed at an endometriosis centre. Unfortunately, the limited number of centres means that they're not able to manage absolutely everyone with endometriosis. But rest assured, hospitals are planning or hoping to have a named endometriosis specialist within every single hospital that will be able to help provide endometriosis care, even in those centres that are not specialist centres. Rebecca, is there anything that you had or wanted to add on centres?
No, I think you covered it all. I think, isn't it, that BSGE centres are set up to look after severe endometriosis cases, and it alluded to the benign cancer discussion that you're having, and it's all about that multidisciplinary input, having folk like Jenny, or like I have a fantastic endometriosis nurse, Becky. We've got links to our fertility specialists, we've got our ultrasonographers, our radiologists, our links to our local charities, etc., and support groups. So it is all about that setup. And as you alluded to, I think there's hopefully going to be a move to the UK to have a named specialist, not necessarily in an accredited centre for the deep invasive endometriosis, but have a named specialist in each areas that can manage endometriosis, but can also have access to some of the services. And I think that's key, because we might have a question on this later, but I think there is a big issue on disparity of endometriosis care around the UK, and I think Jenny will talk about this in terms of Wales and in Scotland. If you compare the number of centres in Wales and Scotland and a tiny bit of London, there's just no comparison. So we need to look at the disparity across the UK. Jenny, I'm sure you've got a lot to say on it.
I actually just wanted to say, ask a question of the rest of panel members, really. Do you think that if endometriosis was not under the umbrella of gynecology, things would have progressed more? Given that women's health services within the health service get the smallest pot of money, and gynecology gets the smallest pot of obstetrics and gynecology, and if endometriosis was considered a whole body disease, do you think maybe things might have gone a little bit further forward?
Martin?
Really difficult question to answer. It's kind of looking back and thinking what could have been. But I tend to want to try and take a positive look forward and say, there are positive steps ahead. There are, lots of passionate members of the BSG Council, a lot of us here tonight that are wanting to drive this agenda forward. There are lots of improvements in funding for endometriosis, lots of current trials underway to help improve what we know for endometriosis. I'm not sure, in response to your question, whether it would have been advanced if it was under another specialty. I do think that as gynecologists, we are best served to be the focal point for managing the disease. I hope that perhaps with more funding coming towards women's health and gynecology, we can continue to make strides ahead.
And on to our next topic, which is hysterectomy. So perhaps we'll go to you, Martin. Why might an individual with endometriosis have a hysterectomy?
Fairly simple. Adenomyosis and endometriosis are very commonly coexistent. And adenomyosis, as Suzanne will pitch in a second, I hope, can be challenging to diagnose in its early stages. And if you leave adenomyosis, which is where cells normally found in the lining of the womb are then found in the muscle of the womb, they are left in place by preserving the womb. Someone's pain, which is one of the commonest reasons why you're doing a hysterectomy may persist. So whenever we're having the discussion in clinic, we discuss, what is going to achieve the best outcome that you, as the patient in front of me, want to achieve. And if that's pain improvement, there have been, numerous studies that suggest, excision of endometriosis with a hysterectomy may offer better improvement than excision of endometriosis alone. And that's not to say that endometriosis is in the uterus, because it's not, but we're purely focusing on someone's pain here and what we're hoping to achieve. And then there's more of a question mark about whether or not the ovaries should then be removed at the same time. There is a thought that perhaps the improvement in pain may be slightly better with removal of the ovaries. The risk of recurrence is slightly lower with removal of the ovaries, and the risk of needing further surgery in the future will be lower if the ovaries are removed. But that needs to be balanced and cautiously balanced against the risks of removing someone's ovaries, which is exposing them to premature bone disease or bone thinning from removing their source of estrogen, or perhaps premature heart disease, that person going on to get heart disease at an earlier stage than they would have done had they not had their ovaries removed. So it is a balance. It needs to be weighed up in clinic, and it's an individual choice. No one patient is the same. And I tend to discuss all those options and allow the patient in front of me to make a decision.
And Rebecca, is there an advantage of taking HRT if you've had a hysterectomy and endometriosis, and is the combined HRT better?
So it really depends on symptoms and the type of hysterectomy that you've had. As Martin alluded to, you can have that discussion about removal of ovaries versus keeping ovaries behind. So if we've gone down the route of keeping ovaries behind, then that will not make a patient menopausal after a hysterectomy. They are at a slightly higher risk of going through an earlier menopause, even if the ovaries are left behind. But in the vast majority of patients, they don't tend to need HRT immediately after that operation. If you're doing a hysterectomy and the ovaries are removed, then essentially you are making a patient menopausal. And that's why it's so important to have this discussion in clinic about the impact of surgical menopause and what the post-op plan is going to be. What HRT preparation are you going to go on? If you have a history of endometriosis, then the evidence suggests that it's better to go on a combined preparation. So that's estrogen and progesterone. Normally, if you don't have a history of endometriosis after a hysterectomy and you need HRT, you tend to only go on estrogen-containing HRT because you no longer need progesterone, as that's usually given just to protect the lining of the womb. So once the womb is gone, you just take estrogen. However, with endometriosis, if you just take estrogen, there is a risk that that estrogen could stimulate the growth of endometriosis in the pelvis. So there is a protective effect of taking both estrogen and progesterone, but it's really important to keep an eye on symptoms as well.
I didn't know if Martin wanted to add to that then. So we are down to our very last question, which is actually a question for all of you. We've whizzed through this. What is the single most important endometriosis priority for 2024?
We go around. I'll start. I can see myself at the top and then we can go around. And it's easier, I think, if I go first. But for me, I think it's everything that we've discussed, to be honest, in terms of increasing awareness and advocacy and patient information. But I think the most exciting area is adolescent endometriosis, because I think the more that we increase awareness in the younger patients, we can improve diagnosis, we can offer treatments at an earlier age, and if we can do this at an earlier age, hopefully we can prevent the longer term and more complex sequelae at a later stage and prevent that kind of 10-year delay of diagnosis. So for me, it's all about tackling early diagnosis in adolescent endometriosis.
Jenny?
Oh, tricky. I would say making sure that every doctor and nurse and other healthcare professional qualifying knows what endometriosis is, how it can present, and what to do, what to recommend a woman does if she suspects she has it.
Martin?
Yeah, it's a tough question, Carla. I think perhaps empowering patients to know what they're entitled to. I think we've spoken a lot tonight about gaslighting, and we've seen in a lot of the comments about patients being given misinformation about what they're entitled to or what their symptoms relate to. So everyone that's on this webinar to read the NICE guidelines for endometriosis. They're freely available. They don't take too long. They clearly lay out what you're entitled to, when referrals should be made, what diagnostic tests should be offered. And then there's also a patient-friendly ESHRE, ESHRE guideline that's available for a discussion on the recommendations that are made by our European Society colleagues that we also follow. So empower yourself. Knowledge is power when you're coming into clinical situations where clinicians, unfortunately, have historically, and I hope will not happen in the future, of providing some misinformation.
Jen, sorry?
So hard. So I'm going to try not to repeat, because obviously all of the above. But I'm going to be really mercurial about it and say money. We need money. We need money for experts, money for centres, money for education, money for theatre lists, money for equipment and expert sonographers. We need money for research, money, money, money. So yeah, that's my answer.
Suzanne? Oh, muted. Oh, there you go.
For me, the single most important thing is to get more healthcare professionals to be able to diagnose endometriosis, because it can be seen on ultrasound. It can be relatively easily seen on ultrasound once you've learned how to do it. And so if for all the women who presented to their GP with pain or other symptoms and had a scan, if their endometriosis was diagnosed there and then, what a difference that would make. And so that's why I'm putting all my efforts into that bit, teaching others to be able to diagnose it, because once you're diagnosed, then you can start to actually do something about it.
And Hazel?
I think more funding into research to understand endometriosis and also alternative therapies that can support management like nutrition and lifestyle, and also more research to help get down diagnostic delays.
And Guhan?
I think increasing awareness regarding the impact of endometriosis on fertility and more on the impact of endometriosis surgery on fertility. As I think empowering patients, but also increasing awareness among healthcare professionals who have sometimes, I think, historically perhaps not considered sort of fertility as a priority concern. As you mentioned earlier, Carla, fertility is a primary concern for a lot of patients with endometriosis. So I think including it as almost sort of the mainstay of treatment alongside sort of anything else that may be considered.
So that brings us to the end of this session, but we do have some time left. So I don't know if there's anything anyone would like to add, or if there's anything that we haven't quite covered. I know there's some questions in the box, but we were also sent a whole bunch of questions as well. So we haven't really had a chance to look through. Rebecca,
yours? What was your one thing?
all of the above, every single one, and especially the money into just research, training, support, especially because it's awful, quite frankly. I mean, I was diagnosed in 2015, and having now gone through that and gone through the hysterectomy and fertility, having the stoma and all of that, I've like yourself, Jen, I've never been offered any type of support outside of my family and friends, no guidance, absolutely nothing. So I think particularly a focus on support for those going through it, those at the beginning of their journey, but also those like us who have gone through the hysterectomies and are still young, because there just is not anything out there. And without money, it's very difficult to get that going. So yeah, certainly just support in all areas.
Can I just ask a question? Because there's quite a few that came up in the chat. So it's for Guhan, because we had a few emails in as well. There's a lot of disparity across the UK with regards to fertility preservation pre endometriosis surgery. What are your thoughts on that, and how can we standardize that, because certainly where I work, and I know my fertility specialist, I saw he made a comment, so he's listening this evening, but certainly where I work, that is not funded. We measure AMH and we have that discussion, but there is no funding available for patients to have fertility preservation pre-surgery that might significantly affect their fertility. What are your thoughts on it?
Yeah, no, excellent point. And I think the sort of whole debate about sort of the term benign, there is funding for fertility preservation prior to cancer treatment, but the impact of, for example, endometriosis surgery could be as debilitating on long-term fertility as some cancer treatment. So unfortunately, this hasn't been included sort of, nationally as part of the sort of fertility funded treatment, but I think it's something that should be, and I think it's something that patients, this is how it's become almost routine, that patients have been diagnosed with sort of a cancer prior to having treatment. It's sort of the discussion regarding fertility preservation and its merits. I think this option should become sort of part of the mainstay with regards to sort of endometriosis. But like Jen mentioned, it's sort of money.
Kuhan, what advice would you give for those who are concerned about their fertility but have a low AMH? Because I preserved my fertility, but I had a very, very low AMH. I actually had, my levels were of a 40-year-old, and I only managed to freeze 4 eggs, which is better than none. But what advice would you give to somebody who, like me, in that moment, has a low AMH, ovarian endometriosis, multiple operations?
Yeah, I think what we don't know is these sort of, for example, the number of eggs that a woman should freeze to give a reasonable chance of achieving a pregnancy in the future. There's a lot of research that still needs to go into this, and I think that if we're looking at sort of lower egg reserve and a low number of eggs following a cycle of ovarian stimulation, then the merits of it need to be really sort of discussed in detail, because putting yourself through a cycle of, which is certainly if it's self-funded, to put yourself through a cycle of egg freezing is, and the risks attached to it to potentially give you a low number of eggs, which may not, which is uncertain to whether it may lead to an embryo and a pregnancy in the future. So the merits of it really needs to be discussed. Unfortunately, a lot of patients like yourself, and that is the sort of the final option they have in terms of preserving fertility, and hence sort of the sort of how important it is to bring this up at an early discussion point, even for patients who are not considering immediate fertility. It's about the long-term implications and really assessing that and trying to mitigate those sort of negative impacts of the condition as well as treatment as much as we can.
And it brings that back to that education, that early diagnosis, doesn't it? I mean, for me, it was too late. I got my diagnosis at the same time I received my infertility diagnosis, so it had gone too far and the damage was done. But whereas now, hopefully with more education, more awareness, people will become aware and look out for their future fertility. Jen?
So it's all related to that conversation, and actually you said something, Kuhan, then just that really leads into it well, and that was, is it like in the guidelines anywhere that we should be offered egg freezing or fertility preservation as a standard before even like going down a hysterectomy route? Because that's something that I was never offered. It was very pressed on me that 1 in 4 women end up regretting a hysterectomy, and all this kind of thing, but there was no discussion about potential options if I wanted to change my mind further down the line, or consider that further down the line. It was never even mentioned. I had no idea it was even possible, especially not on the NHS. And I get that a lot from a lot of other patients. And so it was kind of a question to anybody who has the answer or might know the answer to that one. And why isn't it kind of being talked about a little bit more openly as an option?
I'll jump in to over the pause, but also to offer my 2p's worth in that, it's a very high level policy making decision that that these decisions, which potentially have a huge financial impact on perhaps NHS budgets are made. I'm not saying it's the right decision. I'm just saying that, you know, I don't have any control. If I did have some control, you know, I'd certainly want this to be looked into, because I see the impact that endometriosis has on people's ovarian reserve. But it is unfortunately well above my pay grade.
Rebecca, is anything else? Sorry, you go.
No, I was going to jump in and just say it's all down. I think it is down to money, but Martin had I think it is all down to central funding, and yes, it is down to money. But we should be having these conversations, definitely,
and as early as possible. So yeah, I think are we at the end? Rebecca, is there anything that we've missed?
No, I think we've covered most. There were a few. I think I'm going to the fact that we've got Hazel, who's very kindly joined. We've got quite a lot of nutritional questions that I was quite interested in as well. I'm just going to try and find them, and we'll just quick fire a couple at you, and then I think we can close up, because I know. Oh, I'd lost them now. Let me just go back to them.
I have been answering them as we go along.
Maybe that's where they've disappeared to. There was a question I just found on turmeric and ginger. Does that have any benefit in terms of reducing inflammation?
So with turmeric, there is a compound in turmeric called curcumin that has been beneficial for reducing inflammation. We don't have a huge amount of evidence in endometriosis specifically. There's loads of evidence in rheumatoid conditions and inflammatory arthritis and things like that. So a lot of people are hypothesizing that it may be beneficial. In period pain specifically, not looking at endometriosis related period pain, there seems to be a benefit when taking around the menstrual cycle. I don't think there's any harm in taking it. Obviously, supplements come at a cost. It's not something the NHS prescribes, so it would be at your own will to be taking this. But when taken in doses that are recommended, they seem to be very harmless, and they may be effective. So it could be something that you consider including into your regime.
Perfect, thank you. I think you have very kindly answered all the questions that I was going to come to in the chat, and apologies to everyone who's put the questions in. I think we've answered over 100 and there's still over 100, so it just shows how much more work we need to do, and I'd love to have been able to answer them all, but unfortunately I don't think we can get to all of them. So unless anyone has anything else, I'll hand over to Carla to finish.
Are we done? We're done. Well, yeah, I mean, maybe there's room for round two with all these questions that we need to answer. But I just want to say thank you all so much to our panelists for joining us, and for, you know, giving up your time this evening to answer all these questions, and to all those who have joined as well. I know this is being recorded, so you can find it on the BSGE website shortly if you missed it, or if you just want to go back and have another listen. So thank you all, and good night.
Thanks everyone.
Thank you.
Thanks for having me. Thanks so much.
Good night.